Can we start? Good morning, everybody. Am I audible?
Yes, sir.
Good morning, sir. We can hear you, sir.
Yeah. Can we start the session?
Yes, sir. Sure, sir.
Thank you, all the people concerned, for having me on the panel. We have a very illustrious panel of 5 people. I would like to introduce them. Can I start my screen sharing? Yeah. Is my screen visible?
No, sir.
Hello?
No, sir.
Not
You have
yet.
started sharing, still not visible.
1 second. What about now?
Yes, sir.
I'll enlarge it.
Sir, full screen, sir.
Yes,
Make
sir.
it as a slideshow, yeah.
1 second. Yes, full screen. Is it now visible? Full screen?
Yes, sir.
So we have on this panel, Dr. Sambashivam, Dr. Somshekar, our Secretary of the Infant and Young Child Feeding Chapter, Senior Respected Dr. Kumata Madam, Dr. Guna Singh, whom you all very well know, as well as Dr. Adishivam from Pondicherry itself. So I would like to start off with the session making a few introductory remarks, and that is infant mortality and childhood mortality has come down in NFHS 5 from 31.5 to 29.5 under 5. Here you can see 26 to 25 infant mortality as well as neonatal mortality. It has come down. But on the other hand, the nutritional indicators, when we look at, though the stunting has reduced, wasting has reduced, severe wasting has also reduced by 2.1%, underweight has reduced, the ugly head of overnutrition is surfacing. So we now know that maternal nutrition is central to infant nutrition. If the mother is well treated, only then she can have a healthy baby. Low birth weight and prematurity, now we know, are linked to maternal anemia. Now I would like to put my first question to my panelist, Dr. Somshekar. Dr. Somshekar, can you briefly discuss the maternal nutrition and anemia trends and their impact on birth outcomes and stunting?
So thank you very much, sir. First of all, let me thank you for taking up this most important panel, which quite often we neglect. Here is a very important point which you have raised, that the question carries, there are 2 questions, in fact, in your saying that one is about the maternal nutrition and the anemia trend. Mm-hmm. And the next part of the question which you have asked me is the impact on birth outcome and stunting, how this maternal nutrition has got an influence. Let me just brief in one slide that, like all of you know, that there is a food plate. But similar to that, I think this food plate many of you might not have seen here. Here is a maternal food plate. We need to probably capitalize and percolate this into our postgraduates as well as to all the leading practitioners. Out of the 10 food groups, one must at least advocate out of 10, minimum 5 to 6 food groups. That is grains, white roots and tubers, and pulses like peas and lentils, and nuts and seeds, and dairy milk and milk products, and meat, poultry, and fish, which is very important, and of course egg, which we need to emphasize that during the maternal nutrition, while the mothers are pregnant, at least during the 2nd trimester and 3rd trimester, that there is a need for intake of egg. And not to forget the most important, which you often say, insist on the greens, that is the dark green leafy vegetables and other vegetables and other fruits. So this is one thing. And the next slide is that if you consider in terms of the quantity, this which quite often we never emphasize. We need to emphasize that every mother during the first trimester, second trimester, third trimester, how much to eat. That is on an average of 2 regular meals during the first trimester. During the second trimester, add on to 1 extra meal to the 2 regular meals. And during the third trimester, total of the 3 meals, out of that 3 meal, there should be 2 healthy snacks. The snacks consist of fruits, milk and laddu and alwa and other urundai. We say that some sattu urundai, and boiled vegetables and egg, which is very essential. That is a nutrition star. We should emphasize that. So why I should say that the quantity also matters? Because there is a growing evidence that the maternal nutrition status, which can alter the epigenetic status of the fetal genome. This is very, very important. And the one has to also assess the maternal nutrition. How do you assess? There are very simple measures. That is this pregnant mother who has been having a normal nutritional status, so she is not at risk. Is she having a nutritional status at risk, or is she having a severe nutritional status at risk? I'll just brief in 4 headings. That is about her height. If the height is 145 centimeters, she is not at risk. If the height is less than 1 to 45, yes, she is at nutritional risk. If the height is less than that, it is more than severe nutritional status. And next thing which you always we talk about is the body mass index, and is the mid upper arm circumference, and the anemic status depending on the hemoglobin, which all of the antenatal mothers have been touched and being done. The third one is the gestational weight gain. I think Srinivasan will agree that there is a minimum weight gain of 2 kg in the first month, and at least from the second trimester onward there must be a 2 kg increase in the weight gain. And of course other things are the signs of night blindness and visible goiter present or not, is there other things like any other medical complications. And I think that the third thing which I want to say about the key indicators, which I think we'll be able to talk about, when you ask me a question about the anemia status, I think the NFHS 5, if you look at the 4 and the 5, the non-pregnant women between 15 and 49 years who are anemic in the NFHS 5 is 55.4, whereas in the NFHS 5 it is 53.6. There is a good trend there, it is decreased. It is decreased. Where it is decreased? Non-pregnant women. But on the other hand, in the pregnant women between 15 and 49 years who are anemic, that is having less than 11 grams of hemoglobin, is becoming more when you compare with the NFHS 4. It is from 44.4%, it is increased to 48.3%. This is what we need to focus, which is alarming. And the role of folic acid and iodine needs to be emphasized, as well as the calcium. And to answer the last question, what impact our nutritional status in the mother has got with the fetus. This is very important. I would like to say that the anemia starts, it's a life cycle approach. The adolescent girls who are with having a lean body mass index and they are going to get pregnant, they are going to give rise to the adolescent pregnancy, which carries a risk of halted growth, and there is a loss of weight, there is a depletion of fat, as well as they are going to give rise to SEA baby and preterm baby. So this is the major determinant for giving rise to the low gestational age and low weight, and this is what is the need of the hour, that these babies born are going to have a poor cognitive development, impaired learning achievements in school, and there is a reduced productivity in their adult life. They are going to have a stunting. Thank you, sir.
If somebody having any doubts or any question, they may send it in a small paper so that we may able to answer during our discussion. Sir, I think yes, line is cut. Our CRP sir. Can you call? கூப்பிடுங்க sir.
He's there, Gunesh.
Okay, meanwhile, I will start doing that. So next question is to Dr. Sambasivam. Babies need mom-made milk. Why that bottle feeding prevalence is increasing?
Thank you. Thank you for the opportunity for being a part of the panel. Yeah.
CRB sir, can you share the, not audible. So you are not audible. Unmute. Sir, you are muted. I think you can start, sir.
Yeah.
Huh? You can start. Why bottle feeding is going on increasing?
Why the bottle feeding rate is increasing?
Sorry for the delay, very sorry. I'll share the screen again.
Okay.
Just a minute. Thank you, Guna Singh, for chipping in. 1 second, just give me a minute. Okay. Dr. Sambashivam, please continue.
Okay, sir.
Question is already there to you.
Why the bottle feeding is on the rise?
Yeah.
So there are so many reasons for it. Number one is the lack of awareness on the benefits of the breastfeeding, and the number of working mothers is on the rise, and also more number of C-section in the recent past, and another reasons are social changes. The need for the traveling is becoming rise. The commercial influence of the corporate giants and the wrong perception of the mothers, some mothers, that they will be losing weight if they breastfeed the child. And another one is mother and family assumes the baby is not having enough milk, and also not understanding the needs of the baby. எப்பெல்லாம் குழந்தை அழுதோ அப்பெல்லாம் என்ன சொல்றாங்கன்னு சொன்னா தாய்ப்பால் பத்தாமதான் அழுதுங்கிறாங்க. But baby's requirements are only two. Number one is the breastfeeding, next one is the warmth. Baby needs mother feeding along with the warmth. இந்த ரெண்டு ரெக்யர்மெண்ட் தான் ஒரு நியூபார்னுக்கு தேவை. பட் ஆனால் ஃபேமிலி மெம்பர்ஸ் அதை புரிஞ்சிக்க மாட்டேங்கிறாங்க. அவர் கம்யூனிட்டி இஸ் நாட் ஸ்ப்ரெடிங் த மெசேஜ் இன் டு த ஃபேமிலி மெம்பர்ஸ். பேபி அழுதுன்னு சொல்றாங்க. அழுதுன்னு சொல்லும் போது என்ன செய்யறாங்க, அடுத்து வந்து தாய்ப்பால் பத்தலன்னு சொல்லிட்டு வேற ஃபீடிங்க்கு போறாங்க. திஸ் இஸ் a wrong perception. Another one is the C-section. It is on the rise. We all know for so many reasons. But what happens in the C-section? Immediately after delivery, most of the nursing homes, the baby is shifted to the ICU for sake of observation. In that period, they started with some other non-human milk. Baby develops nipple confusion. When the baby is brought to the mother, the baby result in refusal of the breast, so resulting in the lactation failure. So, even in C-section, the baby should be given breastfeeding immediately after birth. C-section is not an indication for a breast commercial food or for bottle feeding. Once bottle feeding is introduced, baby will never turn up to the mother. As per the latest study, the breastfeeding, the bottle feeding rate is around 30% in our Tamil Nadu. It's a very alarming sign. Even though in Tamil Nadu, hospital delivery, institutional delivery is more than 99%, the breastfeeding rate is very, very poor. In 1993, it was 51. Even after 25 years, now as per the recent NFHS study 5, the breastfeeding rate, exclusive breastfeeding rate is only 54% only. Only 50. It's very, very, very poor. Why? What is happening? We people are not committed for the promotion of the breastfeeding. We have to support, promote and protect the breastfeeding to reduce the IMR, NMR and MMR. More another thing is Some mothers are thinking they will lose the beauty if they started breastfeeding. It is not so. It is a wrong perception. When the mother put the baby on her breast and continue her breastfeeding, there is a rapid involution of the uterus, resulting in the lower abdomen become very thin. So, actually breastfeeding increases the beauty of the mother. It is not reducing the beauty of the mother. Okay, thank you.
Thank you.
Tell us about the bottle.
Ah.
What does that it means? Previous slide, sir.
Yeah.
Previous.
The bottle feeding definitely is going to kill the baby. But once the bottle is introduced, the baby will never turn up the breast. It will get addicted to the bottle feeding. Bottle feeding results in lot of complications, all we know. Pneumonitis, pneumonia, ASOM, diarrhea, so lot of complications the baby is going to face. So definitely it will result in the baby will kill the bottle will kill the baby. So we never introduce the bottle. Even for a traveling mother, they can go for the EBM, Paladi feed. So, not only that, the public breastfeeding is encouraged now. It is the latest concept. Even in the traveling in buses or in train, they can very well feed the baby. There is no risk at all. Community நாங்க போய் feed பண்ணும்போது the teaching பண்ணும்போது என்ன சொல்றோம், 2 பாட்டில் குடும்பத்துக்கு ஆகாது. Only feeding bottle, another one is another bottle. That bottle, the Tasmac bottle. So all bottles are enemy to our family. So we never introduce a bottle for the family, for the baby.
So there is So beginning of bottle feeding is end of breastfeeding. I think within few days,
You are correct.
child get confused. I just few days by saw, it is a 3 days old child delivered in a corporate hospital. So they were given some frozen human milk, and the mother is giving with bottle. When mother is there, I don't know what is the need for frozen milk. So child got confused, child is not sucking. Please don't do that, okay?
All of you had seen this photograph, a baby inside the bottle.
Can you do something? I think they,
This bottle has been drawn. This picture is captured the vision of everybody who is being interested to the root cause of alleviation of nutrition-related disorder like kwashiorkor. The Cecily Williams, she is a Jamaican physician who has designed this bottle, and there is a baby inside the bottle. So, like Mother Teresa, he worked for the noble cause of eradication of hunger, poverty and kwashiorkor. So, he has devised this bottle with this baby inside. Yes.
okay. So it's myself, okay.
The next is about the Professor Dr. Gunasingh, sir. You have been a strong proponent of the baby-led weaning, and we should not use the word baby-led feeding. So, is there any evidence to show that that is better than the conventional method of feeding?
Okay. So first I tell you this baby-led weaning is universally used. Okay, just I will put it in there. So in some countries weaning is stopping breastfeeding and starting complementary feeding. So actually the baby-led weaning is not like that. So it is started in Gil Rapley's nurse who started this method of feeding. It is popular in Australia and UK. So normally it is parent-led weaning. Mother is giving with a spoon or with hand and the thing. So this method of feeding is self-feeding from 6 months. Okay, normally we advise by 1 year or even 2 years. How I got this idea means about 2-3 years back, one parent brought his 8-year-old boy. The problem is the child is not, that fellow is not at all chewing food. When I went into the history, that fellow was not given any solid food from infancy, maybe by 6 months. It is all food is put in mixie and given in a liquid form. Till 8-year-old boy, it is happening even now. I think it is the right time to say no to mixie. Please, this is very common. We are mixing also, both, I think. Okay, so then I went into the Google, I found out why is this. Then I found out this may be the answer, baby-led weaning. Okay. Eba, can you play this? Can you? Yeah. So this is gag, this is normal, don't worry about it. By 6 months, you start the child on, along with breast milk, you put the finger food like, you can give fruits or you can give a chicken or mutton with a bowl. There are recipes available online. I have started telling the mother, I don't know whether they are following or not, but usually when the mother is eating something, the child catches that food, a biscuit or something. So, okay. So it is possible. I think there are a lot of young mothers are here. Is not, okay. So,
Am I audible?
So what is it?
Dr. Guna Singh? Hello?
Okay. So, lot of studies on baby-led weaning. I think I got this article. So currently there is still insufficient evidence to draw a conclusion about baby-led weaning approach in terms of adequacy of energy and nutrient intake due to low quality of the evidence, because you give some selected item, individual item. Now we have a period, put everything inside, I mean in a rice, dal, vegetable, then you give to the child. So, but when you give individually, there may be some problem for iron, zinc and other thing. Nevertheless, other evidence from most recent randomized studies suggests a modified baby-led weaning means along with self-feeding from 6 months, the child may be given a period food also. So, including recommendation about the introduction of selected iron-rich food as well as avoiding foods at risk of choking might have been positive preventive effects on the risk of choking and nutrition deficiency. Food fussiness was significantly lower in bliss group infants than control at 6 months but not at 24 months. So, we may need a further investigation in a large randomized control study. So, what do we think? We need to teach them how to eat, but it is not necessary. We never teach them how to walk, how to sit. It is a basic reflexes. So I think we need to start practicing self-feeding so that it may diminish the feeding problem. I think every day you see many parents are forced to, telling that my child is not eating. I just tell them, don't worry, if the child is not, say, it's some sort of responsive feeding, that's all.
Hello? Am I audible to all of you?
Yes, sir. Yes, sir.
Sorry, there was a technical problem. Suddenly my screen went off. I would like to add a small point with Dr. Guna Singh, what he has shown an excellent video on baby-led weaning. What we know is when the baby is in utero, it knows only to suck and swallow, which continues for up to 4 or 5 months. Following that, lot of tongue movements, jaw movements, getting the food onto the side, chewing, all these things will be gradually as the child is growing. These all the activities of mastication, taking food to side, chewing on it, biting on it, and trying to swallow, all these are developing. Very nicely it has been brought out, Dr. Guna Singh. I must congratulate you for the video. By 9 months, self-weaning should be a rule. Now I would like to request Dr. Kumta Madam, kindly go ahead and tell us that there is said that exclusive breastfeeding brings down the child-infant mortality. To what extent it helps, Madam?
Definitely, sir. Actually, Lancet series child survival.
Kumada, your voice is...
Guna Singh, you please, I am unable to share the screen. You go ahead with...
No, Kumada, voice is very low.
Okay,
1 minute, I'll improve the mic. Now, can you hear me?
Yes, sir.
It's okay.
Now, can you hear me?
Yeah.
Yes.
Okay. So the Lancet series on effective interventions for reduction of under 5 mortality. It was a very good study which told us all the reasons or interventions which we have to be undertaking, especially in middle income countries. In fact, Lancet series compared our Indian data on these various effective intervention packages with other 42 countries. And what stood out of these effective intervention packages, those interventions where all of you know that exclusive breastfeeding, antibiotic coverage for PPROM, clean delivery, neonatal resuscitation, ORS therapy for diarrheal diseases. There were so many intervention packages. Out of this intervention packages, the one which stood out very high and tall was exclusive breastfeeding. So it is not only exclusive breastfeeding, it is also early and exclusive breastfeeding. So that reduced to the tune of 15%, which no other interventions, of course, parallel with that was oral rehydration therapy, which is also 15% in reduction of mortality. Added to this, complementary feeding, which is again another 6%, we would reduce our mortality by both IMR and under 5 mortality to the tune of 21%. So there is no other evidence required to say that these babies can be saved. And you could see the slide here, oral rehydration 15% and again breastfeeding 15. In fact, when it was compared with other countries, 42 other countries, exclusive breastfeeding was 1% higher in saving under 5 deaths. So that is very, very important. And if you look at our data, as Sambasivam said, we have for Indian data 88% institutional delivery, but our early initiations is only 51% for India. Though it is increased for Tamil Nadu from 55 to 60%, our institutional deliveries are 99%. So we are losing 39% of children in failing to do early initiation. And again, if you look at our exclusive breastfeeding rate, it is only 55% as against India. According to NFHS, it is 60%, 61.9 in fact. So we are much failing. So we, as Tamil Nadu state, we should know that we are failing not only in early initiation and also in exclusive breastfeeding, where we have to take appropriate actions.
Thank you, Dr. Kumata. I'm unable to share the screen, so I request Dr. Guna Singh to change the slides. Hello?
Yes, sir. He is doing
Okay,
it.
so what is the role of, what is the mean, SIHFW in mother means?
It is state.
In mother and infant nutrition for the first 1,000 days. I don't know what is the expansion of that. Please go ahead, Kumita.
Health and Family Welfare.
It is State Institute of Health and Family Welfare, but in our state we call Health and Family Welfare Training Centers, which are not only central, we have 5 to 6 regional centers.
Kumita, a little louder, please.
They play a very crucial role in training material. See, first, this family welfare centers are platform for training, conducting TOTs, not only conducting TOTs, but also developing teaching materials. If Government of India gives guidelines in English, it is translated and converted into local languages, regional languages in our state in Tamil, and then it is given to the middle level health functionaries. And not only that, they also plan curriculum for pre-service training of frontline workers, like our ANM village health nurse and other nursing curriculum also. And not only do they plan curriculum for pre-service, also they plan curriculum for in-service training. They play a major role, as Guna Singh knows, that in NSSK there is feeding. In essential newborn care, breastfeeding is important component of NSSK, and in IMNCI, both facility-based and community-based IMNCI, breastfeeding and complementary nutrition forms an important part in the training given by the Health and Family Welfare Institutes. And also the currently implemented MA program in 2016 They were the important people who did dissemination, creating awareness, and also doing TOTs and middle level training for ANMs, doctors of not only the primary health uh, services, but also to director of medical services and director of medical education where deliveries occur. So all the delivery point people or functionaries require training about the first 1,000 days of nutrition, which also includes the maternal nutrition, as Somashekar says, and all this is taken care of by this institutes in Tamil Nadu.
Thank you, Dr. Kumita. This was a very good answer. The State Institute of Health and Family Welfare is responsible for training all the health functionaries. If you want to talk about infant nutrition, maternal nutrition, adolescent nutrition, we have to, all stakeholders have to be brought into the purview and their capacity has to be built. Can I now ask Dr. Adishivam, what is the role of
One more question is left. I'll finish that before you hand over to Adisiva. The iron requirement, one more question is there.
Yeah, that's a very important one. Please, yeah.
Shall I answer that?
Please go ahead. Please go ahead.
Okay. We are worried about maternal anemia, which is a cause for low birth weight and preterm babies. And also we are worried about anemia in children. So the government of India has taken an important step, what is called as Anemia Mukt Bharat program, under which there are 6 categories of beneficiaries have been identified. These 6 categories of beneficiaries are 6 months to 59 months. That means 6 months to 5 years of age, and from 5 to 9 years, another group of children are identified, and 10 to 19 years, and then pregnant and lactating women, and non-pregnant women and non-lactating age 20 to 49 years. We should be very careful, see that this program is implemented. In fact, now I've started even in my private practice for giving iron prophylaxis for children above 6 months, irrespective of the category from which they belong to, either normal weight, low birth weight, or preterm. So these babies, 6 months to 59 months, they require.
Kumada, little brief. We have only 10 minutes left. We have another some 15 questions to be answered.
Okay, I'll say these categories are receiving iron. 6 months weekly iron twice, and 5 to 10 months they get weekly iron, and 10 to 19 years both adolescent boys and girls they have weekly iron, what is called as WIF program. And pregnant and lactating women, the program has been changed to from 100 milligrams to 60 milligrams iron for 180 days instead of 100 days, both lactating and pregnant. And what is new in this Anemia Book Bharat is non-pregnant, non-lactating women also receiving iron weekly once again for the one whole year weekly during the whole reproductive age, so that we prevent maternal anemia. Thank you.
Okay, thank you.
Thank you, Dr. Kumata. I now go to Dr. Adishivam. Your question is, what is the role of human milk banks? What is the current status of human milk bank in India?
The first human milk bank in India was started way back in 1989, but for the initial 25 to 30 years, there was not much interest in human milk banking. There was only around 15 to 20 milk banks in the country. But over the last 5-6 years, there is renewed interest in the area, and till date, there are more than 100 human milk banks in the country. It is easier to start a human milk bank, but sustaining it with a voluntary human milk donation is the key. Just like any other blood bank also, if the voluntary milk donation is not sustained, then most of the milk banks will go dry. So as you can see these two pictures, the one the color shows the neonatal mortality in red, and those with less neonatal mortality in green. We have compared it with another map showing the clustering of the human milk banks. You may notice that there is enough number of human milk banks in the green areas. That is, where there is decreased neonatal mortality, human milk banks are there. That doesn't mean that only human milk bank is saving newborn, but it is an added factor to make a lot of preterm babies survive. But we should also note that in those red areas where the human milk banking is very essential, there should be more efforts to start the human milk banks. Just like exclusive breastfeeding, human milk bank, the pasteurized donor human milk after pasteurization may lose some of the immunological components including Ig and IgG. However, it is 1,000 times better than human milk formula. So it has been proved beyond doubt that just like exclusive breastfeeding, even pasteurized donor human milk can decrease the incidence of necrotizing enterocolitis, sepsis, bronchopulmonary dysplasia, and all these things are important for the survival of the newborn babies. The next is, sir, please move the slide.
Yeah, they are
Press-
not allowed to open my video. They say your host has muted you.
By human milk banking, we are not undermining the importance of exclusive breastfeeding, but in fact, it goes hand in hand. In our own center, we have shown that after starting the milk bank, the exclusive breastfeeding practices have actually improved. So, improving human milk donation
Host has stopped my video.
and also improving exclusive breastfeeding simultaneously can go hand in hand. More importantly, improving kangaroo mother care for low birth weight babies as well as preterm babies can also improve exclusive breastfeeding rates inside the hospital and outside the hospital, and also simultaneously improve the voluntary human milk donation. Government
Thank
has
you very much, Adishivam. I hope you have completed your response. We are falling very much behind time. Now I would like the next slide to kindly come on. I'm unable to share the screen. Yeah. So Sambashivam, can you quickly tell us, you have done a lot of community work spreading skill-based knowledge. In 1 minute, can you summarize it quickly, sir?
Okay, sir. Okay, sir. Okay, sir. We do the intervention in various levels. We do conduct workshops for the ICDS staffs and nursing staffs, student nurses, and also for the doctors, and also for the family members in the community. We have conducted more than 100 workshops throughout the state of Tamil Nadu, and we have covered more than 10,000 people in the work, during the workshops, and also we do distribute pamphlets, awareness pamphlets to the auspicious occasions in marriages. This one marriage distribution marriage in my friend's daughter's marriage in Pondy. We also distributed pamphlets to Dr. Somaphagus son's wedding in Neyveli also, and also we took class for the common man, for the family members of the postnatal mothers in government hospital Kumbakoram. I am doing this for the past 3.5 years. We do conduct classes for the antenatal mothers and also the family members. So far, we have conducted 265 classes in GH Kumbakonam. The cumulative total participants is 11,400 people. So, we do come across all the possible ways to pass on the information to the hospitals. And also, what we confer is, in the ideal period for breastfeeding promotion is antenatal period counseling. Counseling in the antenatal period, not only for the mothers and also for the whole family members should be involved in promotion of the breastfeeding. Okay, thank you, sir.
Dr. Sambashivam, that is a very good point. A mother who is committed to breastfeeding can be a great educator to everyone around her. Now, Dr. Gunasingh, you know there is obesity is coming up in NFHS 5 and you are very much interested in that. Can you quickly tell us about how we are going to prevent obesity in children?
So many advertisements says by exercise you can reduce the weight. I am sure you cannot reduce your weight. Just now my student, Kannan said, sir, I am doing exercise. He is having a big belly, no? So I said, you cannot reduce it weight. Please never prescribe exercise to reduce weight. It is diet alone. Prevention is vital. Once child becomes obese, you cannot do anything, I am telling you. Even especially in childhood obesity. A healthy diet, please avoid all ultra-processed food. That is most harmful. Highly palatable and so much of sweet, salt and everything. As I told, it is responsive feeding. Pasicha kudukanum, pasittu pusi. Otherwise, don't worry about it. You have to insist on that. Parents should be the role model. I see all father, mother all become obese and the child also became obese. When you advise all those things, they become very sensitive or okay. So never mix. They sit in front of the TV and eat. That is the most harmful thing. Growth monitoring. I do all children in my clinic, in my hospital, growth monitoring. Unless you please add BMI chart also. Unless you identify the risk of obesity, you cannot do anything. Exercise is good, but it may not reduce in helping the weight of the child. You can advise NEAT. I think you can go into the Google and what are the things you can do that in non-exercise activity thermogenesis. Just going to the nearby shop, they take vehicle and go. They just order everything on online and eating. That should be avoided. Pediatrician should be the role model. I think we should avoid all junk food in the parties or other thing, and we should become fit. We cannot have a obese and we cannot be a role model. And in conferences also I tell, Ismail, I hope today banquet there won't be any chips and other thing, ultra processed food. You can avoid that. Traditional Indian diet is the best one. I think we need to do that. Thank you.
Thank you very much, Dr. Guna Singh. Can we go to the next slide? The question will be to very nice that obesity is becoming a big problem. We want to know from you that after completion of 6 months, what is the right time to start start non-vegetarian diet for non-vegetarian families?
So, World Health Organization, IAP, AAP, everyone advise all non-vegetarian diet, meat, poultry, fish, eggs, everything can be given, should be started by 6 months if religiously acceptable. And previously you will see American Academy of Pediatrics, previously it was telling eggs should be avoided. Eggs should be avoided till 1 year. Fish should be avoided by 2 years. Now everything is gone. Even in an allergic prone child with history of allergy in the parents, all food should be, they say it should be started earlier to avoid food allergy. So there is, I always tell in the exam, they tell 1 year, 2 years. Please, if religiously acceptable, you start doing that. And another thing is about the vegetarian diet. Is it vegetarian diet bad? No. Well-planned vegetarian diets are appropriate for individuals during all stages of life cycle, including pregnancy, lactation. They say they are risk of calcium, this, that and all. I ask them, I tell them, you get milk from cow because of for the calcium. How the cow get the calcium? From grass. So you need to plan. You eat flesh of the other animals. How they get iron? From grass only. So it is possible. You go to the blue zone. Google and blue zone. Blue zones are the healthiest people in the world, supposed to be. They live longer. They live happily. So they say 90% of their diet is vegetarian diet, but plus lifestyle, they do good exercise, they have family life, happy, wife, happy husband. So all those things are important. It's not only diet. So please go to the blue zone, how they live and thank you.
Thank you. Very nicely you have said that emotional health, spiritual health, wholesome health is also very important. Diet, of course, does play a very big role. We need to know what we should eat. Now, I would like to come to the end of this panel discussion, but there are some important questions. Somshekar, a question to you. In the COVID has really, last 2 years, everybody is displaced, misplaced, what all has happened. Now, can you tell us, in this pandemic, what has happened to the nutrition status of women and how you are going to integrate mother and infant child feeding into undergraduate and postgraduate teaching?
Thank you, sir. I must acknowledge the UNICEF consultant, Dr. Rajalakshmi Nair, for sparing this slide. The first and foremost is that I would confess that the 21 million women have become pregnant during the COVID times. Can you ever imagine that? The government imposed lockdown, but these people have locked inside the bedroom. Maybe that is why the reason for so much rise in the pregnancy. And you can imagine the job losses, the economic distress, the supply chain disruption. There is a 10% loss in the salary, which resulted in 1% decrease in the intake of protein, and there is again 8% decrease in the carbohydrate intake. On the other hand, as you can see, in any petty shops even, the nutrient-rich foods are becoming very costly. They are sold 4 times higher, and like a staple food like grain, fruits, veggies were not affordable, and even it was not available. So this is the reason that they become really deprived of the nutrition, succumb to all sort of complications. And next thing which I would like to quote here is the India Global Hunger Index, which has taken to out of 117, it is positioned at 102. It is highly alarming when compared to the neighboring state like our country like Bangladesh, it is only 88, but whereas Pakistan it is 94. And there is always an allay of, anxiety that among everybody, among the parents, that the children also going to get COVID-19 and missy and so on and so forth. And the second question to answer to you is the most important, which how are you going to take up this MIYCN into the medical curriculum and among the medical practitioners? There were many courses available online about maternal, infant and young child course which is available, and there is a certified course is there. And what I would like to convey to all the participants who are present here, like the catch them young is the slogan, that when as they become interns, like soon after they complete, before they get their MBBS degree, there must be a one-day sensitization course like PMC course. There is an emergency medicine course available, like IMNC module has been taught right from the second year onwards. Like similarly, this MYCN course has to be inculcated, incorporated into the medical curriculum during when they pass out and become when they get their degree. So in your practice, how are you going to adopt this? With whom, where and when? When these antenatal mothers come to the OP, which I think Dr. Sambhav has been very passionate about doing it since after his retirement, he goes every day, his vehicle moves automatically, engine starts automatically on every Tuesday and Friday. It is driven to the Kumbakonam GH, where he counsel all the antenatal mothers, so you can catch hold of the father and the healthcare providers, mother, sister, sister-in-law. Those people, sometimes the community persons are more important. And next, the contact point is when they come to the preparation for the delivery, and next contact point is the labor. And of course, the ECD also now teaches that the 11 visits when they come, these are the touch points and the contact points soon after delivery, 7 days, and the 6th month when these mothers, this is the bottleneck again. Now all of us are very aware that IAP also propagate and been celebrating the Complementary Feeding Day, June. That is the 6th month when these mothers bring their baby. You tell them to bring the baby during the 6th month. You spend a minimum of 6 minutes to spend and spend your valuable time in a busy OPD. Tell them about what are the 4 groups which you need to emphasize. Tell the mother what is available, and subsequently when they come for measles, and subsequently at 18 months, and it goes on like. So if you probably assimilate this knowledge about maternal from antenatal and subsequently up to 2 years and 36 months, I think we'll be able to score and give adequate nutrition. We can make our children healthy and better citizen of tomorrow. Thank you, sir.
Thank you, Dr. Somshekhar. That was a very nice response. So to sum up our maternal, infant and adolescent nutrition, we would like to present a few key information. Can you have the previous slide, please? Previous slide. Yeah, maternal nutrition, especially iron, folic acid consumption. Dr. Kumuta madam has nicely emphasized. 70% of the India's population is anemic, and very nicely she said every child above 6 months needs to be getting iron. Every woman needs to be getting iron. Very, very important point. Sambashivam has so nicely told about antenatal counseling. At birth, it is skin to skin contact. Snuggling of the baby and mother in the first few days of life is extremely important. Delayed cord clamping has known to bring down anemia. Ensure establishment of lactogenesis in all maternities. The MBFHI, Mother Baby Friendly Hospital, and 10 steps. Let's not go into details. Next slide. Next slide, please. Yeah, observing and assessing a breastfeed is very, very crucial. I think that is one which should be very grossly highlighted. We all say, oh, you feed the baby, but how she should feed, how she is feeding, how things are happening, it's a science and art. Home-based neonatal care at 15th day, if the baby has not regained the birth weight, there is problem. Remember, it's a red sign. The date of birth, 6 months to be added for exclusive breastfeeding. Wetness test can be used. We immunize all our children, but along with immunizing, growth monitoring and promotion, weighing the baby, making sure it has gained good weight are extremely important. Counseling skills, implementing the IMS Act are other important points. Next slide, please. The last slide. Complementary feeding, we have 5 or 6 pearls to summarize what we have said so far. We have to give thick semi-solid ganji. Dr. Guna Singh has nicely told us about baby-led weaning. At the same time, don't make the food very thin. The child must get used to all sorts of foods in its mouth. By the time you give MMR, it is time to make sure the baby feeds itself rather than parents forcing the food onto it. The dietary diversity using 5 Gs, greens, grains, grams, grapes, vegetables, as well as ghee, the 5 Gs, there is diversity of food is very important, which should be kept in mind. As the baby is growing, we have to increase the feed and monitor the growth. Village Health Nutrition Days are a very powerful tool, which happens once in a month, 21st day of every month in every village. Quality of these visits can be improved by our pediatricians and frontline workers. A last point, our babies fall sick almost once in every month. Feeding the baby during an illness and following an illness are also important. Can we go to the next slide, please? So we thank you all for this panel and listening. Thank you all.
Thank you very much, sir, for having accepted to moderate this session. I think let all our panelists stand up and would like to give you a standing ovation to the father of infant nutrition, Dr. Bana Purmat, sir.
Thank you.
Thank you very much.
Thank you.
Humbled. Thank you. Thank you.
Thank you so much, sir. I now request Dr. Gopal Subramaniam, Treasurer, IAP Tamil Nadu State Chapter, to give away the mementos to the panelists.
Let Dr. Guna Singh say about the statue as you see here.
இந்த சிலை வந்து நம்ம ஐசிஹெச்ல முன்னாடி வச்சிருக்கிறோம். ஸோ இது வந்து ஒரு சம்படி மெட்ராஸில் ஒருத்தர் திடீர்னு ஏதோ நெட்டில் என் பேரை பார்த்துட்டு அது திருவண்ணாமலையில் செஞ்சது. ஐ திங்க் அரவுண்ட் 1.5 lakhs. He donated to me. Then I told our director ICH, அப்போ ஜெயச்சந்திரன் இருந்தார், இந்த மாதிரி ஒரு சிலை வந்திருக்கு சார், என்ன பண்ணலாம், எங்கேயாவது ஒரு இடத்துல வைக்கலாம் அப்படின்னு. அவர் தான் இல்லை நீ இந்த இடத்துல வைன்னு அங்கே முன்னாடி வச்சாரு. ஸோ ஐ ஹோப் ஸ்டில் தேர். சீனிவாசன் அது ஏதாவது வீடு அது என்னன்னா, அது சிலையை வச்ச உடனே மக்கள்லாம் வந்து ஊதுவத்தி ஐ மீன் அது என்னப்பா கற்பூரம் வச்சு அதுக்கு அதனால பாலம்மா அப்படின்னு ட்வின்ஸ் பாலம்மானி கூட நாங்க பேர் வச்சிருந்தோம். தாய்ப்பாலம்மன்.
லைட்லாம் போடுறாங்க டெய்லி, வெளிச்சம்லாம்.
Thank you, sir.
Thank you.
Dr. Gopal Subramaniam to Dr. Somashekar, to Dr. Guna Singh, Dr. G. Samasivam, and Dr. B. Adishivam. We thank Dr. Bana Purmat and all the panelists for an excellent panel discussion.
Don't forgetting Dr. Kumata.
Yeah, sir.
Yeah, madam is already there.
We honestly thank Dr. Kumuda Madam for joining us through Zoom.
Okay.
Yes, sir, solid. We now have the most important Dr. Jayaraj Ayyanadar Oration Award in Hall A. This is a plenary session and there will be no concurrent sessions in the other halls. I request all the delegates to assemble in Hall A to witness the most important event of Pudvai Pedicon 2021.